Good afternoon, everyone. I'm Mike Strozinski, Executive Vice President and General Counsel at the Massachusetts Health and Hospital Association. On behalf of the entire team here at MHA, I'd like to welcome you to today's webinar, Effectively Transforming Service Options. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in a listen-only mode. The questions will come directly to us. We'll do our best to address as many as we can at the end of the presentation. I also want to take a moment to thank MHA's 2025 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of many events we offer throughout the year to connect our members with leading experts on timely issues. With that, I'm pleased to introduce today's speakers from Manatt Health, Doug Brown and Eric Gold. Doug is a partner with Manatt with over 35 years of senior experience in law, medicine, and government. Many of you know Doug from his decades of leadership in Massachusetts hospitals, including as an executive in the UMass Memorial System. He has served on the boards of both MHA and the American Hospital Association. At Manatt, Doug now works with clients on a full spectrum of healthcare issues, including policy, regulation, community care, with a focus on crisis management, governance, litigation, healthcare mergers and acquisitions, investigations and reviews, Medicaid issues, and government advocacy. Eric is also a longtime healthcare leader and partner to the hospital community here in Massachusetts, most recently serving as chief of the healthcare division in Massachusetts Attorney General's office. As a partner in Manatt's Boston office, he handles government and internal investigations, state regulatory matters, and health policy engagements. He leverages his experience in government enforcement and healthcare policy to advise public and private clients on complex matters involving healthcare access, insurance coverage, behavioral health, and other regulatory issues. We are tremendously fortunate to have their expertise and partnership as part of our healthcare community here in Massachusetts. And we're grateful for both of them being here today and very much looking forward to this discussion. So without further ado, I'll hand it over to Eric and Doug to get us started.
Great. Thank you so much, Mike. It's good to see you. Thanks for that kind introduction, and good afternoon to all of you who are tuning in. Eric and I are really pleased to chat with you about this today. So Nick, if you can go to the next slide, let me just try to tee up what we're hoping to talk about in the next 45 minutes or so, and would love to get your questions and engage in dialogue. Our hypothesis is that there will be less revenue in healthcare, and especially true for hospitals. And when Eric and I were first thinking about this, it was actually before the Big Beautiful Bill Act passed. And so, of course, that's even more the case now. And when that happens, it's quite likely that hospitals are going to have to be far more discriminating and discerning in what they do and what they don't do. And that will likely lead to service changes and probably service closures. The reality that you will likely to experience, certainly my observation, I think Eric's as well, is that the community is often not aligned with what's going on in your reality, which is to say that the community doesn't care much about how difficult your life is becoming, just given the lack of revenue. When you close a service or change a service, their expectations are at a very different place. And so my experience going through this is that it is one of the most difficult things that I did in my career, and certainly my entity did. So, it's not, we think it's inevitable. We don't think it's likely when you have to do this that your standing will dramatically improve in the community. I think that's probably a fair statement. But we also believe that there are a number of steps you can take to mitigate the damage. And we think it's particularly important to be thoughtful and proactive about it. And that's really our goal in presenting this today, to try to set some context, kind of review the regulatory scheme with you, and then focus on a case study that we did at UMass Memorial because it seemed to have everything in it. And from that, derive some lessons learned that hopefully we can share with you in terms of takeaways and thoughts for how to do this as well as you can going forward. So with that, why don't we move into the next slide? We'll just give a very brief background. You've already heard everything about me and I think about Eric. So Eric, unless you want to add anything, I think I can turn it over to you and you can go to the next slide.
Yeah, just very quickly, we can go to the next slide. Thanks, Mike, for the kind introduction. Just about our firm. I think many of you know Manatt Health. Manatt is a legal and consulting professional services firm. We do work in all 50 states and have been here in Boston now about 5 years with a lot of growth in the last 2 years since Doug and I have joined the office here. So look forward to talking to you all today and hopefully continuing to work with the hospitals across Boston as we're doing. We can go to the next slide.
So to set the context, and I imagine much of this is well known to all of you, I'm gonna talk a little bit about these things, and then I'm gonna ask Eric to give a few thoughts on what's on everybody's mind, and that is the big beautiful Bill Act. Because Eric's done a lot of thinking, and I think we want to just share our view on what it's going to mean for Massachusetts. But 340B, we were lucky that there was nothing in the act relating to 340B. I think none of us expect it's not going to be tweaked and changed in some way. That's going to have a big effect. Of course, supply expenses due to tariffs is pressing hospitals in a significant way. We all know what's going on in the immigration domain and how it's affecting staffing. It's going to continue to affect staffing. It has a huge impact on post-acute staffing, which of course affects hospitals and their ability to discharge patients. So we're going to see that continuing. We've seen significant cuts to research that has a big effect on institutions in Massachusetts. And then, of course, the population continues to age, and the complexity of patients continues to grow, and there's much more focus on chronic care, all of which is having a big effect. And while the public payers are reducing their payments to hospitals, none of us expect any particular relief on the commercial side, unfortunately, as well. So it's certainly a tough environment for sure. Eric, do you want to just mention a little bit about our recent act?
Yeah, so I'm sure you all know on the 4th of July, the president signed this new Republican reconciliation legislation, now known as HR 1, which really imposes quite sweeping changes to federal support for Medicaid as well as commercial insurance available through the state-based marketplaces, including the Health Connector. So the CBO estimates here are that this will cut about more than $1 trillion in federal funding across the country to Medicaid and marketplaces over the next decade, and that millions will lose health insurance coverage. Our firm's Manatt's done our own analysis by state, and we're projecting about $30 billion in cuts to federal funding in Massachusetts over the next decade. The particular changes in the Medicaid program really focus on the Affordable Care Act expansion population. It includes mandatory work requirements and what we're calling work reporting requirements, really a lot of paperwork that'll be required there, requiring certain enrollees to pay co-payments and other cost shares, and increasing the frequency of eligibility redeterminations, all of which will result in fewer people being enrolled in Medicaid. There are also significant restrictions and limits to provider taxes, which will allow the states to raise revenue and also pull down additional federal funds, limits on state-directed payments, which are ways that state Medicaid programs have historically made supplemental payments to safety net hospitals. Those are going to be severely limited, and other various restrictions on state financing of Medicaid. There are restrictions on reproductive health access, including defunding, as you said, may have known of, right, of Planned Parenthood, and other restrictions on Medicaid funding for a year for abortion clinics, and significant restrictions to access to coverage for immigrants, much more than exist under current law, applying both to Medicaid, but also to access to coverage through the connector and Medicare as well. So I think the combination here is much less money in the healthcare system over the next decade and fewer individuals with access to health insurance coverage, both public and subsidized care through the commercial plans through the exchange.
Great, thank you, Eric, for that. Nick, you can go to the next slide. So before I turn it over to Eric, who's gonna take us through the regulatory scheme when a hospital has to face a service change or closure, I just want to mention this that you may find useful. The link is in the bottom if it's of any interest, but a colleague of mine, Naomi, and Eric's, Naomi Newman, who does a lot of work with academic medical centers. We wrote this article a few months ago on kind of specific action items that health systems leaders could take in these very disruptive and uncertain times. I just wanted to lift up three. Obviously, we're doing a lot of work with systems now on scenario planning and being proactive about how to make investments in certain ways. This has always been important for health systems, but it's especially important now, given limited resources, to be much more thoughtful and intentional about where you want to make your investments. I also think, and it's not getting much attention, but I think governance has always mattered a lot in healthcare, especially in nonprofit healthcare. We've seen some of the problems in Massachusetts with the Steward issue, and I think governance is going to continue to be pressed as organizations reinvent themselves, as they engage in consolidation, and as they really have to think deeply about their mission and how they connect to the community. It's really a good time to just make sure your governance is refreshed, that you have the right policies in place, your bylaws have had a look, your organization is functioning in the way you want it to function to best enable the decisions you need to make. And then the last point, there's a lot of gloom and doom, and I don't want to make light of that, but it's also important to find opportunities even in this administration, and there are certainly some. The agenda coming out of Washington is pretty focused on primary care, preventive care, chronic disease management, food as medicine. I mean, a lot of your organizations have been pursuing initiatives in this regard. So I think it's important to keep an eye out for opportunities where you can find some synergy and make some progress with this administration. Next slide.
Great. Well, thanks, Doug. So switching gears a little bit, I mean, that's sort of what the setting is, I'll call it in the real world operationally. But it's helpful to understand the context of when a hospital or health system needs to make a service change. What is the legal and regulatory context? So with a caveat that I'll come back to, that I think we don't think this should be driving decision making at organizations, but it's good to know the context if this is not on your radar already. So the Massachusetts state law does require notice to the Department of Public Health before any termination or closure of any service line, any essential service. DPH is the only state agency that has this regulatory authority. And it's important to note that DPH cannot, in Massachusetts, legally require a hospital to keep a service open, but the statute and the regulations do require that the hospital go through this process. So the process applies to what the regulation calls an essential service, which is really anything, any inpatient or outpatient service, except for 9 excluded services, which are pretty limited, basically nursing homes and a few other specific things. So if you need to close a service, you should assume that you'll have to go through this DPH process. And the process, as I said, provides this mechanism for the department to review the proposed closure or reduction in services and to ensure that measures have been put in place to minimize the impact on the community and patients and address any concerns that have been brought to the department's attention. Again, this is meant to be a collaborative process, ensuring that any adverse effects from the service closure or bed closure are minimized. Um, and any discontinuation of services within the facility or a satellite inpatient or outpatient have to go through this process. We can go to the next slide now. So, it's basically a 4-month public process, and I'll go through it at a very high level here. There's a several page long regulation, and DPH has more detail on their website. But it starts with a 120-day very brief notice to DPH. Hospital also has to notify the patient and family council, their staff, unions, and local and state elected officials, basically just at a high level. What is the service? When do you intend to close it or to reduce the service offering? Then at least 90 days before the closure date, you need to provide a formal notice to DPH. This will be a lengthier, sort of full description of what is being closed, what the anticipated patient impact is, what is the hospital's plan for engaging with the community, for minimizing that impact and addressing the community need. Then the DPH will take that notice and they will schedule a public hearing. That's at least 60 days before the closure, so within 30 days of the notice generally, and they'll publish that notice on their website and also in the newspaper in the community. Again, this public hearing is meant to provide interested parties the opportunity to share comments with the department about the closure. And Doug will go into this, I think, in some detail in the UMass case study. But these can be very different in some instances. The public hearings, and these can usually happen both in person and people can attend telephonically. Will just the hospital employees or staff or patients might give some supportive comments, but it can also be a circumstance where lots of local elected officials and community members can be very vocal if they have concerns with the hospital's proposal. So it's important to note and to focus on the public hearing. And then after the public hearing and after DPH reviews the materials, they will reach a conclusion as to whether these services are necessary to preserve access to care in the community. If so, they will require the hospital to submit a plan to ensure access. That might be, for example, a transportation plan to provide shuttle service or Ubers or other ways to get patients from where the service used to be provided to where the next closest available location. That service access plan, as it's called, has to be provided within 15 days of the DPH finding, and then there's an opportunity for further comment before the final service closure. So again, DPH has opportunity to go back and forth with the hospital here. There is this process. They have the opportunity to provide comments. They can request further detail from the hospital and request further detail around an access plan. But ultimately, even if DPH is dissatisfied with the hospital's decision to close and dissatisfied with the service access plan, they can't stop the closure and the closure will go forward. Okay, the next slide. So it's important to note that despite the fact that DPH is the only ones who do a formal regulatory review of service closures, there are lots of other interested elected and unelected folks around who have an interest in what hospitals are doing. Even within the state government, you'll have the governor's office, you'll have the Secretary of Health and Human Services and Mass Health, the Attorney General and the Attorney General's office staff, legislatures, senators, representatives, the Health Policy Commission, all of whom in the past have taken an interest in hospital service closures, despite not having a formal legal or regulatory role. Some have done this privately, some publicly, some with direct interaction with hospital leadership, sometimes just through public reporting of information and data and interaction with patients or others. And then outside of the government, you'll have, or outside of the state government, you'll have federal congressional delegation. Our 2 U.S. senators and state representatives have gotten involved before. Local elected officials are almost always involved in reviewing and speaking, either supporting or sometimes opposing service closures. You'll, of course, have clinicians and other staff at the hospital who will have a strong opinion as to whether the service should or should not be closed. Patient advocates, and other community groups, the staff, the employee unions, often the nurses union or other employee unions who are most often opposed to the service closures. And then, of course, the media. If it's a Boston facility, the Boston Globe, and in local communities, local media will often focus on any important or any change in service at an important local institution like the hospital. So put together, I think, and we'll talk about this more at the end, it's important to think about the full gamut of actors inside and outside state government that really play an important role in determining whether the hospital can successfully transform this service beyond just the Department of Public Health, which is engaging in a very narrow review for purposes of complying with the regulatory scheme. We can go to the next slide now. And Doug, you want to?
Great, thank
take it
you,
away.
Eric. And just to underscore Eric's last slide, I will tell you that in the case I'm about to describe to you, we had every single one of those influences outside of the regulatory scheme. And so everyone wanted to show us the love in this matter. And it's really important, as Eric said, to keep all of those factors in mind. It almost makes the regulatory process seem like a small part of it when you think of all the influences. So don't forget it. So why are we telling you about this case? Well, primarily because we think that it's a really helpful specific context within which you can understand, assess, and get prepared on dealing with these issues. But the other reason is that I think I'm still suffering post-traumatic stress disorder, and it was very painful. And frankly, if I can help one person have less pain in the future, it would all be worth it. I should say that I did check with Eric Dixon to make sure he was comfortable with me lifting up this story, and he said he would love it to serve as a case study, and he'll be in the front row. I checked with Kate as well. Everything I'm going to say is been in the public domain. So UMass Memorial is happy to have others learn. So let me describe the case at its basic level. It was the decision by UMass Memorial to close the labor and delivery unit at the Health Alliance Clinton Hospital at the Leominster campus in Leominster. It had a maternity ward for a long, long time, and it had some issues that started really about 10 years ago, and they started with a maternal death in the unit, which no one ever wants to have, and that caused a deep assessment of whether, as a system, we wanted to keep that unit open or not. And the chair of OB/GYN at the Academic Medical Center got personally heavily involved. And there was a decision that we wanted to keep it open, and we want to invest in the service to make sure it can provide the best possible care to the community. A number of things were done at that time, including updating the facility, investing in new equipment, investing in team-based training for the group, And there was actually quite a bit of progress that was made. This was now around 2017, 2018. I should say that at one time, the unit was delivering over 1,000 babies a year. That had kind of slowly been declining. By the time we closed the unit, it was under 500 births a year, which is really below the levels that is considered, best practice to deliver safe care. But the unit had stabilized and the volume had stabilized and people were feeling very good. And then COVID hit and all sorts of problems emerged. Of course, the organization, like so many of yours, kind of refocused on attending to COVID patients and saving lives. And then once we came out of COVID, as you all know, there were significant staffing challenges across the board. It severely affected this particular unit. It started with nursing. We were having real trouble in staffing the unit with nurses. The team there did reach out to the M&A to see if some of the postpartum nurses would be willing to cover labor and delivery to make it a little easier for us. That was met with an unwillingness to do that. So we didn't have the ability to do that. We then reached out to the Department of Public Health and had conversations with them about seeing if we could have some flexibility during certain times when we had low staffing from complying with all of the requirements because we were having difficulty being able to do so. And we got a similar response from the Department of Public Health, which was, no, you have to fully and completely meet our regulations or you need to close the unit. We then had physician challenges. We lost a number of physicians, went down from, I think, 10 to 2 or 3. It was really difficult to staff the unit. And so a decision was made, a really difficult decision that we have to close the unit. Next slide. So the basic reasons were that, and I remember, Dr. Dixon really looked to the chair of OBGYN and would have been quite comfortable keeping it open. It wasn't a financial decision. It was really whether we could continue to provide labor and delivery care in this community in a way that would be appropriate. And there was just, given all of these challenges, a decision made that we can no longer do so. A few other factors to keep in mind. The academic medical center, UMass Memorial Medical Center, was less than 30 minutes away. A third of the community was already voting with their feet and choosing to deliver their babies at the academic medical center because it's really a world-class center in terms of the staffing, the volume of deliveries. And so the idea that we had was to keep all the prenatal and postpartum care in the Leominster community, that birthing parents could continue to get their care before delivery. They could continue to get their care after delivery. The only thing that was going to change was that they would have to now deliver their baby in Worcester, 30 minutes away, which we believe and continue to believe was in their best interest and the best interest of their baby. We did, as Eric mentioned, through the process, in conversation with the Department of Public Health, we offered kind of an Uber type service for non-emergent transportation assistance. So one of the concerns was whether women would be able to get to their appointments, if they'd have transportation issues, if they'd have to go to the medical center for some reason. So we established a service that would allow them to access it and just call a number and get transportation assistance. By the time I left a little over a year ago, this was not utilized very much, which was kind of our suspicion, but it was available to anyone who needed it. there were significant investments that UMass Memorial made in the Health Alliance in the community in other ways. The organization pursued an anchor mission. They were doing a whole bunch of investments to address social determinants of health in many different ways. The other thing I should mention is that Harrington Hospital, which some of you may know, is also within the UMass Memorial family now, and has been for several years. Harrington went through a very similar decision. This is probably now, I think maybe 5 or so years ago, where they had to close their OB program. It was before they were within the UMass family, but they worked very closely. And they set up all sorts of protocols with the Academic Medical Center in Worcester to make sure that they could handle the volume to cover. Harrington also decided to keep care in the community before and after delivery. And that it did inform our decision, and that went swimmingly, which is to say, didn't have much community backlash, very successful, no issues with patients, and as you'll see, a completely different story in Leominster. We have a whole bunch of speculation as to why that's the case, but couldn't get two more opposite situations for doing the same thing. Next slide. So what was the fallout? Well, virtually everything you can imagine. The M&A, who had really drawn a line in the sand about any further closures of maternity units, they picketed quite often and made a huge issue for it in the community. There was a public hearing that is part of the process, as Eric described. We were well represented by outside counsel in that hearing. I remember turning to our lawyer and saying, that hearing seemed pretty bad to me. But you must have seen ones like it. She said it was the worst that she's ever seen, just in terms of the number of people, the attacks, the accusations, the misinformation that happened. It was just very significant. The community was incredibly ginned up. The state auditor launched an investigation of the maternity unit. The mayor of Leominster decided to sue the organization to try to stop it. The governor even showed up on an OB unit on an unannounced visit one day. And there was a continuing, what seemingly endless number of unfavorable news stories. Next slide. So now we'll kind of try to use this case study to both wrap up, draw some conclusions, and mostly try to cull out some lessons and thoughts as you may have to think about going through something like this in the future. So what happened? What's the end? The service did close on the timeline that we wanted it to close. So in that regard, it was successful in accomplishing its goal, but it resulted in significant stress to the organization, to the board, to leadership for many, many weeks. I think when you go through this, as I kind of said at the beginning, some damage to one's reputation is probably inevitable. No one likes to do this. It's the last thing that hospital leaders want to do. It's not why any of us got into healthcare, but it is important. And in our case, we looked at the volume that this was serving. We believe that it was not likely to provide good care, which obviously is a concern. And frankly, there's an opportunity cost because the rest of the hospital was jam-packed and we were prevented from providing our critical care to severely, sicker patients in many ways. And so it was really important in our view to do this. I would say that proactive outreach is critical. The earlier that you can start to identify and start to have conversations with the community, to have the community understand what the hospital is going through, how you make decisions, what kind of challenges there are. It's really, really important. The relationship with regulators is something I'm sure you're always trying to nurture. It was very, very important in our case. We had very good relationships with DPH, with the Health Policy Commission, with the Attorney General. All of those regulatory bodies were involved in some way, and the fact that that they knew us, that they've worked with us, I think helped a lot, and that really is critical as you go through this. Why do I think it was so different from the Harrington example? There are probably many reasons, but it was a perfect storm of sorts in terms of timing. Post-Dobbs, there was a significant focus on women's health issues. I mentioned the union kind of drawing a line in the sand. They had gone through this at Beverly and other places, and they were going to make this their poster child. You know, I do think that the decision-making process that we went through, the substance, was all correct. I mean, we knew it was going to be really, really difficult. And there are probably certain things I would do differently. I would say that any of the faults or the mistakes that we had, I'd attribute to myself in the process. But I do have to give huge credit to Eric because, you know, I've worked with a number of CEOs in my career, and there are so many points in this process where all of those other influencers that Eric showed, Eric Gold on his slide, can get you off track. There was enormous political pressure and influence that was put on Eric Dixon to change the decision, to delay the decision, to stop the decision. And he because he was absolutely convinced this was the best thing for patients in that community, he did not waver one iota. And I've never seen more pressure brought on any hospital leader in my career, from the governor to legislators to the mayor to everyone. And he said, look, when it comes to patient care, I don't give in to anyone. And he really believed it. And I think it was his determination and resilience at the end of the day that got this done. Next slide. So now we'll just kind of wrap with some of our thoughts and takeaways, and we're gonna share this. But again, would love to engage you in any thoughts or questions that you might have or comments. But you know, I'd say one of the most important things you can do as you're starting to think about this is to put a kind of multidisciplinary team together. As you can imagine, our process involved legal implications. There were huge PR implications, government relations, HR implications, quality. And one of the things we did really well was from an early stage, get a group together that processed this together and addressed issues and talked about issues and made decisions. If you do it with too narrow a group, you're going to miss a lot of key constituencies that are going to be necessary to allow you to make good decisions. The second thing I would say is you have to focus on patient care and patient-centeredness. Now, it's true, and Eric and I have talked a little about this, and Eric will share his views, that a lot of the decisions you're going to have to make going forward may be financially driven, but you have to tie it to the larger story of your mission, and everything at some level is financially driven. I mean, we know we can't operate without the right finances, but within what finances you're given, you have to make judgments and decisions on what's best for the community. So tie it back to your mission and to patients as much as you can. That's really important, I think, for the community. Focus on the data, make your process data-driven. In our case, workforce issues were huge. We had to demonstrate and show that that's real. That's not just, you know, Chicken Little stuff. We actually couldn't staff the unit. We had real data on the volume changes and the dramatic decline in deliveries over several years. That data was important. So make sure you focus on the data. I think this question about, be prepared to answer if you get a quality issue, well, can you resolve it? Could money take care of it? How can you do it? Again, in our case, money couldn't really solve this problem. We couldn't just, buy people or buy doctors or buy staff. And I think it's an important issue to grapple with and make sure you can answer. And then as I mentioned, impact on other services is really important. So this was having an impact in that we could use those beds for other needs in the community, and that was really critical in the end. So now Eric's going to talk a little bit about strategy, and I'll conclude with communications.
Yeah, so I mean, my key takeaway from my seat, sort of as a former regulator, is maybe a little ironic, but not to let the regulatory requirement drive the process and the decision making, right? I think, as Doug said, you need a patient-centered, holistic, broad decision making. But even once you've come to the decision as to that this service needs to be changed in our hospital, and yes, you have this DPH 4-month process in the background that's going to mean that you can't decide today and close it today. But you need to think about, okay, what is going to be the best for our community, for our hospital, for our organization? How much time do we really want? And who do we need to bring into that conversation and when? Now, the time is going to need to be at least 4 months, but, and this is sort of jumping to the last bullet, but maybe you want to make this a 6-month process or a 12-month process, and figuring that out, not just based on the DPH regulatory timeline. And the second point is begin the proactive outreach as soon as you can, right? And this might be quiet, private conversations with other leaders in the community, with your department heads at the institution, at the organization, with some of the key government officials who can keep this private if it's something so important that you need to be talking to the governor's office, to leadership at the AG's office or Health Policy Commission. These organizations know how to keep confidential information confidential, but if it's something where you're expecting a lot of community opposition, those proactive outreaches early are important. And then, of course, carefully assessing the politics. This is always hard to predict how different people are going to respond. But if this is likely going to engender a lot of local opposition, that should be part of your planning process. Is the opposition going to be from the unions? Is it going to be from local elected officials? Are there patients? Are there staff? All of those things, assessing how and when you're going to be proactively communicating this. Understanding strategy for staff, if this is a service closure that's going to result in sort of staff redundancies or needing for reductions in force, can those staff be reassigned? I think we know there's still, in many areas of healthcare, understaffing. So is that something that can be that where the clinicians here and other hospital staff can be used in other places? And then again, just understanding when you are sort of going to launch this publicly. The DPH notices are public, so if you don't communicate it publicly before then, it'll be on the internet and it'll be reported by press who read the internet, read the DPH's website. But there might be good reason why you want to announce this through other channels, not just through a one-page letter on the DPH website, but through communication with local elected officials, with community groups, with patient organizations, to be so that the organization, the hospital, is driving this strategy and outreach, not the DPH regulatory process. Anything more, Doug, on communication that you want to share?
Yeah, just quickly, communications are so critical. I mean, do not underestimate the need to communicate really effectively and to think about it well. You need a clear, crisp message. In our case, the struggle is always, you want to be as transparent as possible with the community. That always I think builds trust and inures to your benefit. You certainly want to be honest. But, you know, who wants to go out and tell the community that the care that you're providing you don't think is up to where it should, right? It's a very difficult, nuanced question, and we struggled with it a lot. You know, you know, especially for the lawyers in the group, there's a tendency to want to be very guarded and very careful and not get things out there that could pose risk. And I think there's a tension between that and what leadership often wants to do is to just be as transparent as possible. The other issue you're going to have is with your elected leaders. You want to get to them early. You want to have conversations with them, which is important. But, you know, if there's a risk that they could leak this to the public, which is not an insignificant list, it could cause the message to get out way ahead of you and get out of control. So that's something you have to navigate very carefully and very well, and is difficult. And then, you know, bring patient stories when you can. If you can get patients on your side through these things and talking about things, it makes a really profound difference. And then I would just say, you know, make sure that you are always bringing it back to your mission and put this in the context of your larger goal to the community, what you're trying to provide, why this is responsible and good stewardship of your assets. And with that, I think we've concluded. If anyone has any comments or questions, and feel free to reach out to us, to Eric or myself offline as well. We're happy to share any thoughts, but we'd certainly welcome any comments or questions people might have now.
Folks, one moment. But thank you both for really unique perspective based on your prior professional roles. Sort of, either side of the aisle here as a regulator and firsthand in hospital leadership. So I think it's very helpful, valuable information, and I think it also serves as a great example of the type of value that Manatt can bring to hospitals here in Massachusetts. So if you folks are looking at these challenges, I don't know if there's anybody better than these two gentlemen here to help you think through and guide your path moving forward. So Eric, Doug, thank you very much. To those of you watching, we'll send around the slide deck for today. Thank you to everyone for tuning in. And as we sign off, hope you'll consider joining us again in the near future for an upcoming MHA education program. You can either visit our website at mhalink.org to see those upcoming programs, or scan the QR code that will populate on your screen here momentarily. You go there, you can check out all of our upcoming events. Hope you all have a great afternoon. Manage to stay cool. Eric, Doug, thank you again very much for today's presentation.
Thanks, everyone. Thanks,
Pleasure.
Frank.
Thank you, Frank.